which is a wonderful institution. She is the DBT clinician at Peachtree Comprehensive Health, yes, in Atlanta. And she has been working with children, with adolescents, with adults, and with families for over the decade. And she is experiencing many, many DBT programs, DBT, RO-DBT, DBT for trauma, PE DBT, DBT-C. I didn't even know that there is a protocol adapted for children. Yes, and you also do Theraplay, yeah, if I remember correctly. Okay, lovely. So I know that you have some presentation for us today.
Yes, I have a PowerPoint. Do I just share my screen?
Yeah, I think if you can, oh, lovely. No, it's not that. Can you share the screen? Or is it?
I just wanted to share just before we start, because maybe that will be interesting for you, Kimberly, and because we have just translation Marsha Linehan's book that was published in April this year in Poland. So we are really happy that you are with us here. Good. And wanted to share this information with you. So I just shared it for a little bit and I will stop it now. And now I can give you, you will be able to share your screen with no problem, I hope.
Yes, we can see it.
You see that?
Yeah, it's fine.
Okay, so thank you so much for inviting me. It's an honor to be here, to be able to be a part of this conference. I've watched multiple components of it. It's really interesting how you're pulling it all together. So hopefully my goal this morning or today is to help to demystify the diagnosis by helping to understand the etiology of borderline. Because for me, if I understand something, then it can take away some of the frustration of it and understand where it's coming from. So I'm going to build off of a lot of the pieces that Dr. Fox talked about, but going more into the etiology and the early development of individuals with BPD. And so I think part of the reason we're all here today is because unfortunately BPD is more than a diagnosis. It has become a label that's often misunderstood and stigmatized. And I've gotten, unfortunately, clinicians as well as loved ones of individuals with BPD who will say they're manipulative, or they're treatment resistant, they don't want treatment, they're scary. And a big myth is that they're just out attention seeking, right? Their behavior is just attention seeking. They don't want to get better. And a lot of times there's that anger is personalized, right? Like they just don't like me, or they're just attacking me. And so when all of that happens, then we get the client, then the client on the other side of it is feeling ashamed. They feel lonely. Imagine reaching out for help and being told, I don't treat that. So I've had clients come to me and say, I think I have BPD, and I've contacted other clinicians and they say, we don't treat BPD. Well, imagine already having this diagnosis of that is lonely, right? That is emotionally intense, and then to have a professional say, we don't treat that. And so that feeling of rejection from somebody that they're actually reaching out for help. And that's my hope of helping to educate on, yes, it can be scary to treat suicidal clients. And sort of like Dr. Fox said, some of the most interesting, intriguing clients I have BPD traits. So they're not, they are not the stigma that everybody puts on it. And then the client then feels like nothing will ever work. No one's ever going to understand me. So as I'm going through this, I want you to think about just think about this. Dr. Linehan mentioned this, that people with BPD are like having third-degree burns. Personally, I've never had third-degree burns, but I can imagine if you've had third-degree burns, anytime anybody even comes in your proximity, you're going to feel sting. It's going to feel like they're touching you even if they're not touching you. And so the clients with BPD coming into treatment are coming in raw. They're coming in with these exposed burns, that their emotions, it's like that they're lacking that emotional skin. So the slightest touch, the slightest emotion is going to feel extremely intense to them. So when we're looking at the etiology of BPD, and Dr. Fox mentioned this briefly, that genes, biology, and the environment come together they influence each other. The genes in the biology is often underappreciated. I think that's a piece that's missed because there's not a genetic test to say what your child's temperament is going to be, right? And so you're not necessarily, you don't have a child and you're not, oh, I get it, they're going to be emotionally intense. So you don't usually recognize that until it's like everything is okay until it's not. And so Dr. Linehan developed the biosocial theory, which is what I'm going to get into, that has helped me as I was originally going through all of this early on in my career, to understand where this is coming from and understand what has influenced these components to get to the point of when we see the clients in our office. And so looking at that biological predisposition that these clients have, and then how that has been exacerbated by an invalidating environment. So I like to use the analogy of like crying over spilled milk, right? Like, so these clients are, usually when I'm talking to parents, they'll say, yeah, when they were 2 or they were 3, it was so hard to console them. They were so emotionally, spilled the milk and it was the end of the world. That type of scenario usually is what is being described. So whenever a child is born sensitive, again, we don't have a test to determine what your child's temperament is going to be. They have a lower threshold for that emotional reaction. And so their responses are usually out of proportion to the situation, right? And so it may make sense that your friend doesn't respond to your text, or like some of my adolescents now say, like they left them on red, right? Like whatever the new sayings are for being what they perceive as being ignored. It would make sense that maybe they feel sad or they feel lonely. However, an individual with BPD, that emotional reaction and that response is typically out of proportion. So then they would go and they may sleep all day, or they may not want to leave, or they would maybe self-harm or do some other self-destructive behaviors that is out of proportion to the actual situation. So just like we all have different thresholds for pain, the same is for emotions. And individuals with BPD have a lower threshold for emotions, which goes back to that myth of that they just don't want to get better, or they just want to be this way. They don't, right? Like nobody wants to be miserable. And so when I have a parent say, I don't think they want to change, they just want to be miserable. And then I'll, when I bring in the client, it's, do you want to be miserable? Or or is it that you don't think that there's any other solution, right? Like I don't know what else to do. These emotional reactions or these third-degree burns, right? Like I don't want this to hurt so bad, and it hurts really bad. And so when we're looking at the biosocial theory, we're looking at the biological, that emotional vulnerable person, plus that environment, that invalidating environment, which then equates to these problems with the ability to understand and label emotions, the lack of coping skills, and then that emotional modulation. We can't regulate an emotion that we don't know what it is, right? So if we don't know what we're feeling, it's really hard to regulate it, or if we don't even know that it's out of proportion, because the lack of insight, right? Like, so we may not even know that it's out of proportion, and all we're getting is the environment telling us we're wrong, right? Like, I feel really upset about this, but the environment continuously tells me I shouldn't be upset, right? Like, that's very conflictual when when it's habitual, and over time, then you learn to not trust your own emotional experiences. And so temperament is inborn, right? That temperament, that intrinsic, when we're born with the temperament is going to come before our personality, for our environment, for anything. It's sort of our genetic set point my sister and I were raised in the same home, same family, and we're very different, right? We have a different genetic set point. We have a different temperament. It is not, she's better than me, I'm better than her. It's just different, right? Sort of like an eye color. You have blue eyes, I have brown eyes. It does not make us any, one better than the other. So that's the way I like to look at the temperament piece of it. And so when we have that biological dysfunction in the emotional regulation system, that biological component, and then we couple that with the invalidating environment. And I put in here social media because when biosocial theory was originally developed, and social media was not a huge environment, right? Like, I think now we have to look at social media as being an environment that influences, right? How many likes did I get? I even had an adult client who said that her husband was upset that she didn't go to his to one of his events, and she said, but I liked it on Facebook, right? Like, so that that social media is an environment that I think for us, that when we haven't grown up in that era, it's really hard to understand how influential that really is for the adolescents and younger adults today, and how that environment really can be an invalidating environment for them, especially with that lack of insight and that interpretation over, nobody liked my picture, right? And so to them, that there's a literal truth in there that nobody likes me. And I think, we can sort of say, like, we have to stop ourselves and say, like, well, that's ridiculous, right? Like, but we would be just as invalidating as that environment. And then that's where the pervasive emotion dysregulation comes as a result of that. So there's three different tendencies that come with this emotional arousal. And so people with BPD tend to have that high emotional sensitivity. So they, what would make me angry or make someone someone else angry may make someone with BPD in a rage, right? Someone that just would get sad, they may become despair and then go to self-destructive behaviors. So you have the high emotional sensitivity and then that high emotional reactivity. And so if most people's emotional baseline is about a 20 from 0 to 100, someone with BPD's baseline is consistently around an 80, right? And so we're more reactive. And so we have that, like, what we would like that puppy, right? Like, so when something comes up, there's that strong reaction to it, that impulsivity and that high emotional reactivity, and then that slower return to baseline. And so there's research to support that slow return to baseline of average emotional intensity. An emotion fires in the brain for about 12 seconds at a given time. Someone with BPD, it fires about 20% longer. And so that return to baseline is a lot slower. And so that's that crying over spilled milk. Okay, you spilled the milk, let's clean it up. It's okay, right? Like that slow return to baseline is like periods of time after that, they're still dysregulated over that milk. And so those are the three separate tendencies that we look at with that emotional arousal. So what we need to teach, and this is where I think it's really important for us to recognize that the whole environmental and biological component to this. And then, so what is it that we need to come in and educate not only, work with the client, but also the families on, remember, their emotional experiences have been invalidated because they've been, so yes, an invalidating environment could be trauma, abuse, neglect, but it could be the most well-intended families with an invalidating environment. So I also will say here that I do the biosocial theory with families to help them understand, and I always preface that it's not a blame model. This is nothing, and I made the mistake of not doing that, and it does come across, it can feel very blaming, like, so you're saying I did this to my family, I did this to my child, right? So I always preface that, again, it's that we don't have a genetic test to say what our child's temperament is going to be. And so the invalidation does not have to be abuse or neglect. It can just be that not understanding that child's experience. So when the child's emotional, the emotion that they experience, their internal emotional experiences are ignored or told that they're doing something wrong, they don't ever learn how to label that. They just say they're wrong, right? Like, I shouldn't feel that way. So we need to help them label those emotional experiences. And we really work in the DBT model, we really work with identifying the physiological response to an emotion to help them identify what the emotion is. So I've had a client once who had said that I'm feeling really angry. And as we're going through this, and I'm like, I'm actually feeling sad as you're telling me this. So I'm confused at like this intense anger that you're having. And so when we tapped into the emotion, to the physiological responses, it was really a lot of physiological responses around sadness, right? But a lot of times with BPD, I can't feel sadness because I'll go into an abyss and I'll never be able to come out, right? And so that secondary emotion kicks in. And so we help them to label those emotions by pairing them and really getting them to hone into the physiological response to the emotion. And then reorienting that attention, increasing or decreasing that physiological arousal. So increasing it may be if they're feeling numb and they engage in self-harm or self-destructive behaviors because they want to feel something, or decreasing that when they're so hypersensitive and that the burn is really stinging, being able to decrease that arousal. And then decreasing the mood dependent behavior, right? Like that reactivity and that behavior that is very mood dependent. Working on the goal directed behavior, and then creating an environment that supports emotion regulation, which is where the family component is really a huge piece of this, because the family has to understand and work to create an environment, not necessarily change, right? It's not necessarily up to the family to change, but to understand and sort of work with the client in supporting that emotional sensitivity that they are exhibiting in the home. So with the invalidating environment, this is pervasive over time, right? It's not just this one time I told my kid to stop, or I told my kid they shouldn't feel that way, right? This is a pervasive over time. And I think this now, coupled with social media, makes it even more challenging than when, maybe when I was growing up and it was just sort of the environment, the physical environment. So there's that pervasive invalidation of the child's private experience. So whether it's true or not, that's how I feel, right? So I feel like really intense sadness. It may not be fit the facts, or it may not be justified, and I still feel it, right? And so over time, that private experience has been invalidated. It's been told, sort of the example of, the simple example of like, I'm hungry. No, you're not. You just ate. Well, but I'm hungry, right? But the environment's telling you you're not hungry. And so it's that pervasiveness over time. Or the displays of emotions are generally ignored or punished. So, I'm not gonna talk to you while you're acting this way, or that if you continue to do this, right? If you don't stop this, then this is going to happen. And so and in that could also be that it gets reinforced, right? The only attention I get is when my emotions are really high, right? You have two kids in the home. The one child is sitting in the corner reading the book, and the other one is having an emotional outburst. Who's probably getting the attention, right? The one with the emotions. And then that oversimplification of just go, if you would just go get out of your room and go do something, you would feel better. Or when the child is, the client, the individual is extremely upset, just, go take a minute and get it together, right? That piece of it's just that simple to just let that emotion go. So the environment pervasively is punishing or reinforcing emotional and behavior escalation. That reinforcement of the environment is going to respond when the emotion gets really heightened. I have a client now who is, I don't know what, if I didn't do this, I don't know if my parents would even pay attention to me, right? Like, it's not true. And that's their perception because that's what they're used to getting attention from. Pathologizing internal experiences or exhibited behavior. So making all of their behaviors pathologizing all of their behaviors or experiences. Criticizing those experiences, those internal experiences of maybe mocking them or, making jokes about how sensitive they are. Being real critical of those internal experiences, because remember, those internal experiences for a client with BPD, they are real. That's what they're feeling. They are not manipulative, right? Like, and that's a hard point. It's like, but she's just manipulating us. No, it may be a learned behavior at this point, right? But the whole myth around manipulation is one that really gets families stuck. Because if you think everything your loved one is doing is manipulative, you're going to approach it in a judgmental way, as opposed to looking at it from a different angle. Or the environment communicates unrealistic expectations for problem solving. So, all you have to do is, start getting out of bed, start getting up and doing things, and you feel less depressed. Right? Like that whole unrealistic expectations. And again, then the environment's essentially telling you that what you're feeling isn't really that bad, right? Like you can just get it together. And so some comments that we hear, unfortunately, and again, these are pervasive over time. Don't be such a baby. It's not that big a deal. And when I do trainings, and I used to work in a psychiatric hospital, and I would do trainings with the staff, and I would say, we are all guilty of this, right? We are all guilty of having the urge to say it's not that big of a deal, because it may not be that big of a deal to us, right? Like it's that piece of their experiences are real. And so when we're telling them it's not that big of a deal, we're invalidating that. And so again, this is not a lot of times this is in the it's not that big of a deal is in an attempt to make them feel better, right? We're not consciously invalidating them. We want them to feel better, to help them see that it's okay. But we first have to recognize that that is their experience. Or why are you so upset? Because they may not know. Right? They may not know why this is upsetting them so bad, which is frustrating, right? Especially, it can be frustrating for clinicians too, because we want to help. And so we want them to, right? Like when we feel like we can't help them, it increases our frustration also, because at the end of the day, we're more human than we are a clinician. We're more human than we are a parent, right? And so that humanized piece is there. The comments that punish emotional expression. If you're going to cry, go to your room. We don't do emotions in this house. We see that a lot with, usually it's, a mix of the parents, but one of the parents is like, we don't do emotions, right? If you want to cry about this, go talk to your mother or go talk to your father. And that also can be confusing because then there's no space to really feel what you're feeling. Or the oversimplification, if you would just do something, you would feel better. You're choosing to stay miserable. That's a big one, right? Like, you have all the tools, you have all the resources you could want. You're just choosing to do this. Or the families will be throwing out, you know, I'll put you in this camp, I'll do this. We've got all these opportunities. If you would just take advantage of them, you would feel better. And so that invalidation of also can come in a form of monetary things, right? Like, if I buy you something, you'll just feel better. I've had a client once that went into went into an acute facility, and the parent was actually sending me pictures of like her house and the items that the girl recently received, and was like, there's no reason for her to be this upset. Look what she has. Right. And that's really hard for an adolescent, because what adolescent, you know, most adolescents want stuff, right? But they quickly realize that, wait a second, this isn't making me feel better. Right? They may not be turning it down because, I mean, adolescents want stuff, and it's that internal experience is not getting better though. And so those parents that is extreme invalidation in those senses of feeling, and it's very hard for them to recognize that, because they think that, oh, I'll just get her this and she'll be okay, right? And so it's a hard concept sometimes for the parents to get. It'll all work out. Don't be upset, right? Time heals those comments. So consequences of that invalidating environment. So now you think about if you're working with clients with BPD, and if you have a historical timeline of their history, and then they're in your office now. Right, and so all of that pervasive invalidation now has morphed into maybe this BPD, or this inability to regulate your emotions. So they're now not able to label those internal experiences. They don't trust their experiences, right? Because they've always been told that they're wrong. No, you're not really hungry. But I am hungry. No, you're not. You just ate. Right, that's that pervasiveness over time, that emotional escalation, very escalative emotional inhibition. They may inhibit their emotions if they've never been able to express emotions, right? If their environment has punished emotional experiences, then they have learned to inhibit them. That perfectionism, oversimplistic or passive problem solving, and then that inability to tolerate shaping, that inability to change. So why BPD may be hard to work with? I think this is maybe a rhetorical question for some of you. And working with suicidal clients can be scary. That's just a reality, right? Like, I don't think any of us can deny that is the reality. But when we understand what got them to the place that they're at, it takes away the judgment, and it takes away, it adds more compassion and more understanding to where they're at, and they're not in here to defeat the therapist, like one of the first myths that Dr. Fox talked about. They are not here to defeat us. They are oftentimes here to get help and to feel better. So super strong, painful emotions that I don't know what to do with equals I want it to stop, and then can lead to suicide and self-harm, right? And so that, again, recognizing they're coming in extremely raw. And so we have to meet them at the place that they're at, because all these emotional experiences are so painful for them to experience. And we as clinicians need the skills also and the tools to be able to sort of work with the clients to recognize where they're at, and manage our own emotions around what they're bringing into the office. So when we're working with clients with BPD, we're in this together with the client, right? We're both rowing in the same direction. We can't, one of us, and that also means that the client can't be working harder than the therapist, right? And so when I orient the clients at the beginning of treatment, I also say to them, if you don't feel like I'm holding up my end of the deal, you need to tell me, right? This is a real relationship between two equals, which is a little bit of a different, I think somebody in one of the earlier talks talked about the relation, a little bit of the relationship piece, and different than other forms of psychotherapy where this is a real, we're in this together. I'm asking you to change really hard things. I'm asking you to be super vulnerable. And so we have to play this little bit of this song and dance together. And so if you don't feel like I'm holding up the end of the deal, I need you to be able to tell me. As clinicians, we have to practice our own mindfulness. Again, we're human before we are a clinician, right? We're human before we are anything else. And so naturally, our emotions are going to increase. Maybe depending on what the client's bringing in, but also feeling like feeling stuck, feeling like I don't know, I'm having a hard time helping the client, right? Like that is a hard place to be. Acknowledging and accepting those emotions that come up. And then that non-judgmental, right? Like being not having the wow response to things, sort of having what, like a physician's approach to it, right? It's not going to shock me. It's not gonna, because whenever there's a wow factor or a shock, that is being displayed, that is being interpreted by them as the judgment, right? Like, wow, I even scared the therapist, right? Like, and so having that non-judgmental and calm space for them to be in, when I go to other programs and like assess other DBT programs and interview the clients, a lot of the times that's the one thing that the client says is, I actually felt like I wasn't being judged when I walked in here, right? Because a lot of, parents and people outside of the field, they don't know how to tolerate self-harm. So the first thing that you would say to somebody that's self-harming is, why are you hurting yourself? Stop hurting yourself, right? And so there's that connotation, that judgment there, that negative connotation behind it. And so just having that non-judgmental space, because the relationship is a key indicator in treatment success here. There has to be that relationship for that client to feel like they can be vulnerable and trust in that therapeutic relationship. And then the typo there. We cannot treat BPD in a vacuum, right? We need a consultation team. That's where the team of DBT comes in. Teams help us get polarized, and so help us from getting polarized. This population, we need support. We need the team to help us in supporting our own emotions as they come up and being able to not get polarized on either side. So when validation is one of the key pieces of communicating with individuals with BPD, and I think individuals in general, really. This is a huge piece of when we, in parenting group and in any type of family therapy, there's always a validation component, because this is a piece that I see the most aha from parents, and the most, where the parents really recognize that how invalidating they've been in their attempts to be supportive and validating, right? And so in the best of intentions, there can still be invalidation. Because validation, it communicates acceptance, and that we feel understood, that we feel accepted, right? That again, that has a huge piece that's been lacking. So without understanding another's point of view, it's nearly impossible to see where they're coming from, right? So we have to be open to hearing that other side, being open to challenging that other side, that other point of view also, right? So if the client says, nothing's ever gonna work, I can't do this, or I can't stop self-harming. So I've had therapists in the outside, like non-DBT therapists that don't treat BPD say they're just not committed. Okay, well, there's a huge difference between not being committed and being completely resistant, right? Like not being committed is, I may have a commitment to going to the gym. I may have a commitment to getting in shape. If I don't go to the gym tonight, that doesn't mean I'm no longer committed to getting in shape. It means something got in the way of following through with that. And so a lot of assessment over not just taking that at face value, helping them see, is it that you don't want to do this, or do you think it's not possible? So a lot of times the response is, I just don't think I can, I just don't think it's going to work. Okay, well, that's a lot different than I'm not going to do it. I don't want to do it. Right. And so there's a lot of assessment in helping to understand that point of view. Because again, they're coming raw without insight and not really knowing. And so when we're looking at validation, I'm going to give you some pieces on validation that are I think super helpful. There's 6 levels of validation in DBT and dialectical behavior therapy. And the first level is just staying awake, right? Which I'm assuming we're all doing level 1 now. Just showing the other person that you're in the room with them, essentially. The second level is that accurate reflection. So you're communicating to that person that you are hearing them. So it may be that you are repeating back to them what they said. And the way that I usually do it is, as opposed to it being just a mimicking back, I'll usually say, I just want to make sure that I understand what you said. And so then I'll rephrase what they said and give them an opportunity to say, no, that's not right. Stating the unarticulated, creating a hypothesis about what the person's telling you, because again, they don't have insight, they don't know. And so they may be exhibiting a lot of secondary emotions. And so creating that hypothesis of, I wonder if your anger towards your spouse is because you feel really guilty over what just happened. But when we create a hypothesis, we have to be okay with being wrong, right? So we have to be okay with them saying no. And sometimes it's like, well, yeah, wouldn't you feel guilty? Absolutely, I would feel guilty, right? Because we're helping them see that we're seeing it bigger than just that anger, because the environment is responding to that surface level behavior and not assessing and looking at there's something behind it. Then level 4 is validating in terms of their history or biology, right? So it makes sense that on some level, right, depending on the behavior, it makes sense that you're feeling so anxious now because last year when this happened, X, Y, and Z happened. And so when we can do level 4, it can help separate the past from the present moment, right? Because oftentimes, especially with loved ones or parents, if they're starting to see warning signs or they're starting to see a change in their loved one's behavior, their anxiety, rightfully so, might increase. And then they're going to react as if that's happening. And so helping them see, it makes total sense that you're anxious now because last time your child did this, they ended up in the hospital. And so when we can separate the past from the present, then we can be mindful in what really is happening now. My anxiety makes sense because of what happened. And is that really what's happening? And we're not reactive to it as if it's happening. And then level 5 is normalizing. Communicating that others with or without BPD would have a similar response. So I use this as a client that struggles with, is this because I have BPD that I'm responding this way? Or, and I use the example of like with COVID, right? People still get the cold, right? There's still a cold. And so just because you have a cold doesn't mean you have COVID, right? Just because I have a sore throat and I'm sneezing, I may just have a cold. I may not have COVID. So just because you're upset doesn't mean that you're upset because you have BPD. It might mean you're upset because the situation is upsetting, right? And so helping normalize that because again, they're experiences have been so invalidated that they've never been able to trust that maybe this does make sense. And so they're always questioning that. And then the level 6, I think, is the coolest part of DBT, is just that genuineness, just being genuine and not having that hierarchical relationship between the therapist and the client, right? Like there's been times where there's been a horrible situation that has come up with the client. It's like, this situation sucks, right? Like that's just, and we are in this together to work, you know, to work on this and to get move forward. But just that genuineness of not feeling, not patronizing their experiences, and that we're the professional, right? Like, so there is that genuineness piece that I think goes a long way. So DBT is considered the gold standard treatment for borderline, for BPD. And the dialectical piece of DBT is we're balancing that acceptance with change. We're meeting them where they're at. We are meeting them, they're raw, they're coming in with those 3rd-degree burns, and we're pushing them to change, right? We're not staying stuck in that raw place. We have to push them to heal those burns, but recognize that that's where they're at. And so we're balancing those emotions, thoughts, and actions, because when we're polarized, that's where misery is, right? When we don't have that balance, that's when that's where misery lies. So we use the dialectics to balance that acceptance with change. And we're teaching them how to identify and name those emotions so that they have the tools to be able to be more effective. So a lot of times clients come in and say, nothing is working. Talk therapy doesn't work. And you know, it can be cathartic to just talk about things that are upsetting, and then you leave and you're like, okay, so now what do I do? Right? Like that felt good to talk about it, but now what do I do? So there's an applicable piece to it that there's actual skills that are targeted to treating the behaviors that they're coming into treatment for. And so where DBT, the balances that decreases that emotional vulnerability, and then it increases the validation, right? But in that, we're also increasing their tolerance of invalidation, right? Because the environment, we can't go into somebody's workplace and make sure that everything that there is said to them is validating, right? And so there is that piece that people may say things that aren't effective, that aren't, you know, or that are invalidating. And there's also working with them to tolerate that. So it's not all about changing the environment to suit the client. It's more about getting them to be able to tolerate the environment. And so there's that neuroplasticity, right? When we're teaching skills and we're having them react differently in times of crisis and do things differently, the brain is forming new neurons, right? Those new neurons, those new connections are built with new experiences. So every time this crisis comes up and we do something different, we do a more adaptive behavior, then we're building new neurons and replacing. So it's more of a replacement, right? Because you can't unlearn a learned behavior. You can only replace it. And so we're putting in skills to help replace those maladaptive behaviors. So assumptions, these are key to working with clients with BPD. And anytime I get stuck, and I tell clinicians, when you get stuck with a client, come back to the assumptions. It could help us regulate our own emotions and help us become polarized. The clients are doing the best they can, right? They're raw coming in. They want to improve. Majority, they're coming into treatment because they want to improve. Do they know how to? Maybe not. Do they think it's possible? Maybe not. And there's an assumption that they want to. And there's an assumption they need to do better, try harder, and be more motivated to change, right? Same thing goes for the therapist. Doing the best I can, and maybe I can do better, right? Like, so these assumptions, again, it's that equal relationship there. clients may not have caused all of their problems and they have to solve them anyway. So this is one where clients don't like to see that one all the time. And because you have, you were an unfortunate, a misfit in your family maybe, right? Like it was a poorness of fit. And we still have to figure out how to solve this. That you can't continue to sit in the space that it was somebody else's fault. The lives of clients can be unbearable. This one can be helpful. All of these can be helpful, but this one can be helpful whenever it feels like there's a personal attack on us from a client, that the lives that they're living are unbearable, that they're miserable in the life that they're living. And so it is not that they are, personally attacking. While it feels that way, right? We can acknowledge that that's the way it feels. When we can come back to the assumptions, it can take some of the steam out of the emotions from us and take away that judgment. And they must learn new behaviors in all contexts. Clients cannot fail in DBT, and DBT members need support. And so we have to be open to and recognize that we need support, and recognize that we are all fallible. Right? We're all going to make mistakes, and we need our team to help us. And we are all going to get polarized, so we need our team to help us stay from that polarization. So when clients with BPT become emotionally reactive, they tend to direct that anger and emotion towards those that they're close to. Right? So this is a big one that I hear from families, like, everything I've done for you, and this is the way you're going to treat me. Right? Or even, from clinicians, maybe, like, I have gone out of my way to help you, and this is what how you're going to treat me. So our natural response is to become defensive. Remember, individuals with BPD lack insight, right? They lack that ability to see somebody else's perspective. And so that perception is their reality in that moment. And so it's our job to validate that, and then to help them in a non-judgmental way see what reality is, right? To help them reframe that. And so trying not to take it personal. When a client feels understood and heard, some of the steam will come out of the emotion, right? They just want to feel like we're not going to walk away from them or reject them, right? Because they have that fear of abandonment, that fear of perceived abandonment. And when you feel stuck, when you find yourself stuck, going back to the assumptions. And I'll end with that BPD is that good prognosis diagnosis, that we have a treatment, an evidence-based treatment that actually treats the behaviors that burn clinicians out, and that are what have used to be termed as untreatable. And here's our DBT-Linehan Board of Certifications Instagram, Facebook, and website if you wanted more information on just that organization. I will stop there and take any questions that anyone may have.
I forgot to unmute myself. There are a few. Okay, thank you, and thank you. I mean, I think both you and Dr. Fox give hope, saying that treatment and recovery is possible and likely, which sometimes people don't believe in, even among mental health professionals, which is sad. Mm-hmm. Even they sometimes believe that it's impossible to treat BPD. So you give a lot of hope for individuals with this condition. Okay. Oh, there is another, there is one technical question. If you could put the last slide back with your addresses. Okay. And then I'm going to this question that I've seen just.
Which slide do you want me to put back?
With your addresses.
Oh, okay. Okay.
Mm-hmm.
Should be pretty savvy with now.
Which temperamental traits are more common in patients with BPD diagnosis?
In terms of the emotional sensitivity, reactivity, and slow return to baseline?
Probably yes.
I think they all are sort of work together. Yeah, I think that's if I'm hearing the question correctly. So those are the three main ones. Is that what the question, referring to those three tendencies?
I think I'm not sure what Marta, could you explain your question a little bit more in details? Pani Marto, jeżeli by Pani mogła jeszcze troszeczkę bardziej uściślić swoje pytanie. And Christine says that you have well thought out and illuminating slides, and she says thank you.
Oh.
Okay. I'm not sure if Marta is still with us, and I cannot, specify her question because it's not mine. I have mine as well.
Okay.
About relationships and individuals with BPD. I wonder if there is an explanation why people with diagnoses believe that they don't deserve love. And this is like the basis of their fear of rejection, yes, and they, difficulties in handling relationships.
Why they don't believe they deserve love. I think they have we have our maybe our faulty thought patterns, our narrative, and then we have our construct. And so they have more of a negative construct around their self-worth. And so if I don't believe that I'm worthy, then obviously everybody else feels that way too. Right. And so my construct is that I'm not a worthy person, that I'm not worthy of love. And so since I believe that, then everybody else must believe that too. And so then there's also that confirmation bias that can come up of trying to confirm, and I think what Dr. Fox mentioned, that their network of their interpersonal network of being others that validate that construct and validate that lack of worth. And so oftentimes we find that when we start to validate somebody's emotional experiences, it can feel uncomfortable to them because that's so against what they believe, right? Like, so if you trying to help them see that they are worthy of love, it's sort of like telling us if we believe we're worthy of love that we're not, right? Like they don't believe it, and so it's like contradictory to what their construct is.
Okay, thank you. One more question from Joanna. A couple of times there have been said that BPD patients often lack insight. How often can it happen that a BPD patient actually has a better insight, and how can that change the therapeutic process?
If they have better insight, how does that change the therapeutic process?
Yeah.
Oftentimes I see the insight coming as we're working together because they're so emotionally flooded and emotionally sensitive that lack of insight is hard to get to, or that the insight is hard to get to. And so when they do have insight, then we're really tackling pairing the skills. Okay, so you see, right, like you have insight into where this behavior is coming from. You have insight into the vulnerabilities leading to this behavior. So now let's really hone in on what can we do to decrease those vulnerabilities, because you understand where it's coming from, right? And so it's really being able to pair the skills so that those emotions, so that it doesn't become so reactive, right? Because when their emotions get really high, they become more emotionally reactive. And so when there's that insight, how can we have you acknowledge that insight before the emotions get so high that you're reactive?
Thank you. How do you educate or work with parents or people related to BPD person?
I start with refer them to Family Connections for that level of support. We run a parent group that is a didactic that coincides with the adolescents. But in terms of like individual parent work, I always I start with just getting a history from them, and then also before even starting, going over the biosocial, sort of very similar to what we went over, with a lot of validation and massaging it through as we're going, because there is that they naturally, and if I was a parent, I would feel the same way, right? Like they feel very shamed or feel very guilty at the end of hearing that. And so really prefacing that the most well-intended parents, the most well-intended environments can be invalidating. And also really pulling in, you know, like the other invalidating environments. So really giving the parents an opportunity to for making that non-judgmental space so that they can say, like, I feel like you're blaming me, right? Like they feel comfortable enough to say, so that their own myths in their head can get debunked. So going over the biosocial theory can be really helpful for the parents, and making sure that you preface that this is a no blame model.
Yeah, and family connections really help as well.
Yes, yes.
It's
helpful for them to hear from other parents.
Okay, question for, there are more questions. What makes a person with BPD often interpret social situations in an extremely negative way, even if that interpretation is objectively extremely unlikely?
So there's that lack of insight, that emotional flooding, right? Their emotions, so they have a narrative in their head. They have that negative construct. And so the way I like to describe it is sort of, the Charlie Brown talk. And so they are hearing the conversation, but they're hearing pieces of it and they're fitting it into their narrative. And so oftentimes when a situation a situation like that, I'll say to the client, okay, is that what your mom said? Yes, that's what she said. So she said, blah, 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 right? Whatever it is. So she said she doesn't want you to live in her house anymore. Well, that's what she meant, right? And so then we can work with that, and so, but again, it's that validating, like, I hear that's what you heard, but is that actually what she said? Is that what you thought she said? Or is that, so it's really assessing, as opposed to, because again, the environment saying, that's not what I said. Stop twisting my words, right? Like that whole invalidation there. And so really getting them to see that, and that's us sort of working with that insight for them to see that, okay, so when my emotions are so high, I'm hearing things that I'm fitting into my own narrative. And then, it's sort of that, like, how did you get that out of what I just said? Right? But helping them see, like, is that really what she said, or is that what you think she meant? And oftentimes it's, well, that's what she meant.
Okay, thank you. And
which can be super frustrating, both on the clinician and the parents, right? Like, because it's sort of that, that song and dance back and forth of trying to help them figure it out.
It can be frustrating for everybody. I think even
everybody, and for the client too, right? It's exhausting for everybody, including the client. Yes.
When it comes to conditioning your work by others, what are the most effective ways to work? Where can I explore this issue? I believe that your self-worth.
I think it's first helping them see who they are, not who they are in terms of, I have a client who identifies herself as depressed, her depressed before her name, and then the mom will list out all the things that she is, right? You're funny, you're lovely, you're intelligent, you're creative, like all of those external pieces, but really working with the client to see who you are. And again, the lack of identity is one of those criteria, right? Like identity is a piece that these clients often lack. And so helping them to see who are you sitting right here? Like, you are sitting in this chair, like really getting them to identify themselves without them identifying themselves based off of their environment and their surroundings.
Okay. Well, another one. I don't know if you can ask you one more question because
Okay,
we
one
are
more, yeah, that's fine.
running. Okay. May you distinguish in few points how to differentiate BPD from bipolar?
So I think, you know, like Dr. Fox talked about the episodic episodes of depression in BPD, whereas in bipolar, there may be more of the manic or hypomanic episodes that are longer duration, where BPD is more, the duration may not be as long. And so the criteria, like really looking at the criteria and assessing the duration of those episodes of, you know, BPD having more of a depressive episode, whether as opposed to that the bipolar having that episodic, you know, the mania that may last for a long period of time. BPD tends to be a little bit more rapid.
Okay. And one more question: where can I explore the issue of no identity?
Like resource wise?
Probably yes. This person is looking for some literature, maybe some books to, some recommendation probably. We will think it through probably.
I will think it through. That stumped me. I will think that through. I don't have a quick answer on that one.
Carolina agrees that we will come to her later. Okay, and there's, I think, one more and last question maybe. How long mania or hypoxia? Oh, no, hey, wait, because the chat is moving. I lost the question, sorry. How long mania may last in bipolar versus BPD versus hypomania?
So say that again.
Yeah, sorry, because the chat is moving and I'm trouble reading. Okay, how long mania or hypomania may last in bipolar versus BPD?
So BPD is I think it all is going to depend. Where mania could last weeks up to months, where BPD is going to be more rapid.
Okay. Yeah, I think there are no more questions. I cannot see them, at least. So thank you, Kimberly. Thank you for us for long 2 hours. And with,
no problem.
Well, we are really, really grateful to you.
Thank you for having me.
When we organize some conference.
Yes, I would love to meet you all in person.
You can visit Poland together with Dr. Fox.
Yes, that would be great.
There are a lot of thank you in chat, mainly in Polish, but okay. It was inspiring that they really loved your speech. Thank you, thank you, thank you, thank you, thank you. I don't know if you can see chat, but you can go for this. Thank you, because they are going for long.
Thank you.
Thank you. Thank you for being with us. You know,
absolutely.
I know you are a very busy person, so it's even.
It was an honor. It was an honor to be here, and I hope it was helpful to give some insight into at least where it's coming. You know, where the diagnosis is coming from.
Yeah, we still need a lot of knowledge.
Mm-hmm.
For sharing.
And just like, you know, I think Dr. Fox said a couple of times, like if it sounds confusing, it's because it is confusing. It is,
yeah. But you know, the most important thing is that there is hope.
Yes, yes, that's the thing. That BPD could be is a good prognosis diagnosis.
Yeah.
And then again, I think going back to the assumptions and going back to that etiology can help take away some of the stigma of, you know, they just want to be miserable and they want to make everybody else's life miserable. Right? It's so sad to hear that that's the perception.
Guys, you can show up and wave to Kimberly and say thank you. Yeah.
Right. Thank you. Thank you all for.
Thank you. We had 130 people here and about 25 on Facebook, so it was
for Saturday afternoon, and we record, so it will be on Facebook and on YouTube as well.
Yeah.
I will share it with you because.
Okay, great.
Yeah.
Right.
Yeah,
Thank
thank
you.
you. Wonderful presentation. I will make print screens for you. Yes.
Thank you. Anything, I would love to join you all in Poland one day.
Well, I think it will be a real pleasure to have you here.
Okay. Thank you. Have a great day. Have a great weekend.
Ends, maybe we can do something.
Okay. Yes. All right. Bye-bye.
Bye.
Bye.